Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Today, I want to talk about the Flexor Hallucis Longus muscle or tendon, or the muscle tendon unit more specifically, and certain injuries or issues that we see pop up with this in dancers. This is a really common thing that we see in dancers, especially tendinopathy of this muscle or tendon, and we often just refer to this as FHL. So it stands for Flexor Hallucis Longus. I'll get into the anatomy of it in a second, but we will often just hear this referred to as FHL, so I'll probably use that throughout the podcast episode. And like I was saying, this is a really common issue that we see in dancers, but that often gets misdiagnosed by other healthcare professionals who maybe aren't as familiar with dance, because it is not a super common problem that we see in a lot of other athletic populations. And I'll kind of explain a bit about why that is the case as we go through. There are some other athletic populations where we may see it. Sprinters are one that we do sometimes see issues with, but really it is a very common issue among dancers. So common that sometimes you will hear this be called like a dancer's tendinopathy, although sometimes people are referring to other things. And so I don't love using kind of non-specific names like that because we don't always know exactly what we're talking about. So for the purposes of today's podcast episode, I am going to be talking specifically about FHL and issues that we see pop up. So the most common one that we see is a tendinopathy or a tendon issue, but we also really commonly see what is called a tenosynovitis, which is essentially inflammation that happens with the covering. So it's called the synovial sheath, but it is like the covering that surrounds tendons in our body. And so we can get an inflammation that happens of that kind of tendon sheath in through there as well, which is slightly different. So that is often, if we have that happening, it is often an active inflammatory process. But it is a little bit different than if we see like a tendinopathy happening at the tendon itself. I'm going to talk more generally about things today and just kind of like in general presentations that we see, but just know that there can be a few different things if we actually look at like a pathological level, what is happening in this area. I'm not going to be that specific about it today, but I'm kind of talking about all of that. If you have not listened to the podcast episode about tendon injuries and tendinopathies and what it is we're looking at when we're talking about tendinitises and tendinopathies, definitely go back and have a listen to that podcast episode, because I think it'll be really helpful for you to understand what we're talking about when we talk specifically about FHL. And also, I have talked a little bit about this on another previous podcast episode. So there is an episode all about posterior ankle impingement. And in that episode, we differentiate between a bony impingement that can happen at the ankle and a soft tissue impingement. And one of the things that can contribute to soft tissue impingement in the posterior ankle is the FHL. So it's a little bit similar to things I discussed on that podcast episode as well, but that one does specifically look at bony impingements and how we kind of differentiate between a soft tissue and a bony impingement and things like that. So if you also have not listened to that podcast episode, go back, have a listen to that one, because all three of these episodes will kind of all make sense together. I will link both of those episodes in the show note. I know that the posterior ankle impingement episode is episode 24. I do not remember the episode number off the top of my head for the tendinopathy episode, but I will link it in the show notes. So just go have a quick peek at that, and you can go listen to those if you have not already. All right, without further ado, I'm going to get into specifically FHL issues in dancers. What are they? What do they present like? How do we treat them? All of the things. If you have been listening to the podcast for any length of time, you probably know that oftentimes I'm inspired by podcast topics by what I'm seeing in the clinic. And there's often like little trends of like, you'll see a bunch of the same thing coming in like a week or 2 weeks or something. And that is the case with this. I've just seen a lot of it recently, like over the last few weeks. And so I thought, you know what? It's time to do an episode about it, because if I'm talking about it a lot in the clinic, chances are lots of other dancers are dealing with it as well. So what is the FHL, or the Flexor Hallucis Longus? It is a muscle, and the muscle belly itself originates in the deep part of the calf. So it actually originates in the leg. It actually originates on the fibula, which is the bone on the outside of our lower leg. So it actually comes from like the outside of the lower leg, and then it wraps around the back of the leg and kind of blends into the tendon, and then the tendon itself crosses the back of the ankle joint. It swings around kind of behind it's called the medial malleolus, but it's the bumpy part of the inside of your ankle. So the tendon slides behind that, goes underneath your heel a little bit, kind of on the inner side, and then runs along your inner arch and all the way into the big toe. So it actually passes, there's these two little bones right underneath the ball of your big toe that are called sesamoid bones, and they're just these little like pea-sized bones that float underneath your big toe joint in through there. And their job is actually to help guide this tendon, so the FHL tendon. So this tendon slides right in between those little two bones, and the bones kind of keep that tendon in place, and then it attaches to the end bone of your toe. So it's called your distal phalanx, but it is the last bony bit on your big toe there. This tendon attaches to the underneath side of it. So it's underneath your big toe. So again, just to recap, it starts in the outer lower leg. It wraps around kind of the inside part of the ankle, and then comes down the inner arch of your foot on the bottom of your foot, but kind of along the medial arch there, and then all the way into the big toe. What is its primary function, or what is its job? The FHL's primary function is that it flexes the big toe. So it bends or curls, like flexes or points is maybe a way of thinking about it, our big toe. But its maybe more important function, or the thing that we are looking at when we're kind of assessing its function, is that it is responsible for stabilizing our first metatarsal. So that is like the bone along the inner side of our foot that's just up from our toe, so our metatarsals. It stabilizes that first metatarsal head and keeps the kind of pad of the toe, so your big toe, in contact with the ground during toe off, or when you are pushing off with gait, or if you're rising up onto demi-pointe and things like that. So it is a really, really, really important stabilizer of, we generally just call it the first ray. So if I'm talking about the first ray, I'm talking about that sort of first metatarsal and then into the phalanx, the toes in through there. The Flexor Hallucis Longus is a really important stabilizer of that first ray in the foot. And it does that function the most when, like I said, you're kind of toeing off, so during walking and things like that, or when you're rising up onto demi-pointe. So in dance, it is no surprise that we then see a lot of issues with this tendon, because we spend a lot of time on releve or on demi-pointe, whereas the general population and even other sporting populations don't spend a lot of time on their toes. So we tend not to see this be as big of an issue in other sporting populations. But because we're often going through releve and rising, we really rely heavily on the stabilizing function of this FHL, and then therefore we can see issues that arise because of that. The FHL also has a secondary function of being able to plant or flex, or that just means point, our ankle. And so if we think about that anatomy again, if you can kind of visualize it in your head, it starts from the outer lower bit of your leg and then wraps around the inside of the ankle. Because it crosses the ankle joint, it has the ability to help point our ankle in through there. It is not a primary ankle pointer. That's not even the right word, but an ankle plantar flexor. but it has the ability to help with that movement. And oftentimes what we see in dancers is that potentially this tendon is getting overloaded because maybe we're not utilizing some of our primary ankle plantar flexors as efficiently as we could be, and we're over relying on this FHL to help plantar flex our ankle, but then also it has that job of stabilizing our big toe. And so all of a sudden it's like being asked to do too many things, and it can get cranky and get a little bit overloaded in through there. So that is essentially the path that the muscle and the tendon take, and their sort of like role or their function. So if we have issues that crop up with this, how does that sort of present? What are dancers going to complain of? What does it sort of feel like? Well, most of the time, dancers are going to complain of pain anywhere along the length of the tendon, but in reality, it can actually be pain anywhere along the muscle belly or the length of the tendon. The most common area that we probably see dancers report pain or sort of experience pain or discomfort is in the back of the ankle. And so again, in that episode about posterior ankle impingement, I go into that in a little bit more detail. But because of where this tendon crosses the back of the ankle and swings kind of under or around that medial malleolus, that is often a place where people will report a lot of like discomfort or pain, or often sensations of like clicking or things like that. However, that being said, you can get pain anywhere along the length of that tendon. And so I do also really commonly see dancers who have pain kind of underneath the medial arch of their foot. They'll come in and say, oh, I think I have plantar fasciitis. But when we actually look at it, we're like, nope, your plantar fascia is totally fine, but we do have an issue with this FHL. Or pain underneath that big toe, especially like rising up onto demi-pointe. They'll often report discomfort like right underneath the ball of their big toe in through there. So it can be pain anywhere along the length of the muscle or the tendon. Like I sort of alluded to before, people will often report a lot of like kind of clicking sort of sensations. They'll be like, every time I point my ankle or every time I point my toes, maybe they can point their ankle and it's fine. And as soon as they try and point their toe or like extend their toe, if they're wiggling their toe back and forth, they'll get this like click, 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 click that happens in through there. That is usually a sign of an FHL issue. So we oftentimes will get clicking. We don't have to, but that is one of like the hallmarks sometimes that we see commonly with this tendon. We can also get what is called crepitus, and that is almost like that's the best way of describing it. It's like a creaking or a grinding or almost like a crinkly feeling within the tendon. It's like not a very scientific word, but if you feel it, you'll know what I'm talking about. And again, this is very commonly happens in the back of the ankle joint, but it can happen anywhere along the length of the tendon. And that we might see more commonly if we're dealing with like a tenosynovitis as opposed to like a tendinopathy. We might not get that crepitus if it's more of a tendinopathy, but definitely something that's common within this tendon and muscle if we have issues going on there. People will often report pain with resisted toe flexion, and oftentimes that is like when they're rising up on demi-pointe or pushing off from gait, or if you just like press, like have them press into toe flexion, but you're sort of resisting that movement, that will reproduce their pain a lot of the time. And then we may also see limitations in the movement and specifically the extension at the big toe. And we often call this a functional hallucis limitus, which basically just means that the big toe is limited in through there, but that it's limited in a functional way, not necessarily like a structural way. So we can have people who have limitation in extension at it's called your first MTP joint, but it's the metatarsal phalangeal joint there. We can have people who have limitations in that joint that are more structural limitations, or maybe they're due to some arthritis in that joint or things like that. And those aren't the people I'm referring to necessarily, but these are people where the joint itself is fine, but when we actually try and extend that joint back, it's limited because the tendon is not allowing that movement to happen. And one of the little tests that we can do for this is if somebody's sitting and their foot's totally relaxed and their ankle's kind of hanging down, so say they're sitting with their feet off the edge of a table or something, their ankle's relaxed. if we bend their big toe back, but we get good movement at the big toe, but then we have them stand up so they're weight bearing through their foot and either on a straight leg or even if they kind of like bend their knees a little bit, so we're in a little bit more dorsiflexion at their ankle, and then we try and extend their big toe back, like lift their toe off the ground, that will often be really limited. Like you'll be like, oh, it's like feels really stuck or really resisted, like it feels like it can't extend back. That is often a sign that there's something going on with that tendon in through there where we're not getting the mobility or it's not allowing the length that we want through that tendon. And so that is one of the tests that we do. And that's actually something that I assess and look at in all of my dancers, pretty much, especially if anybody's coming in with like foot and ankle issues. But even in dancers, if I'm just doing screening assessments for like healthy dancers who aren't complaining of pain or injury, I'm always going to look at their MTP joint, look at the mobility, look at whether there's any sort of functional limitation in there, because it is often a sign that will show up before they have any pain or discomfort. And if we can identify that before we're actually getting like degradation or breakdown in the tendon and before it's becoming like a true tendinopathy, it is so much easier to treat than if we wait until it's like presenting bigger issues. So those are just some of like the hallmark things that we're looking at if people are experiencing an FHL issue in through there. As far as treatment goes from a physiotherapy perspective, we may or may not need to address some amount of like inflammation kind of reduction protocols or that type of thing. Like I said, more often than not, we're dealing with a tendinopathy. And if you have listened to the previous episode on tendon injuries, you know that generally there is not inflammation associated with a tendinopathy. It's more often like sort of like a degradation of the tendon or that type of thing that's happening as opposed to it being an inflammation. However, like I said, some of these are actually like a tenosynovitis, in which case we may be needing to try and address some of an inflammatory component. So it'll depend a little bit on the presentation, but we may or may not be doing things to address inflammation. The biggest thing with these is tendon load management. And with dancers, that generally means unloading the tendon temporarily or reducing the load on it. We don't usually want to completely unload a tendon. And with this one, it's quite hard because it functions a lot during gait. And so most of the time, we don't need to unload it to the point that we're going to like restrict walking or things like that. In some really bad cases, or if we think that there's tearing in the tendon or something like that, we may actually look at restrain or restricting the load in the tendon to the degree that we don't even want their toe extending backwards when they're walking, in which case we may need to look at the use of like a cam boot or a rocker boot so that they're not extending and there's basically, kind of no load going through that tendon. But in the vast majority of FHL issues that you're going to see, they don't get to that point. Like, hopefully people are seeking out care before they get to that point. And so when we're looking at managing the load of the tendon, we can usually allow them to continue to walk around normally and those types of things, but we're generally having to limit their demi-pointe or the amount of like releve and demi-pointe work that they are doing. Because again, with that function of it stabilizing the first ray in through there, that is when it is the most active or there's just the most load going through it. So again, it may not be that we have to completely take away those activities, those movements. It may be that we're just limiting how much of that we're doing. It may be that we need to fully remove those for a time being and say, absolutely no demi-pointe, absolutely no releve, those types of things. So it's going to depend on the degree of kind of issue that is going on. But that is the number one thing we're looking at is loading management for that tendon in through there. We also want to look at foot and ankle biomechanics. It is really common that we'll sometimes see issues with this tendon and other ones in the area crop up if there's sort of some biomechanical issues going on somewhere else in the foot. And so it could be if we have like a restriction somewhere in, especially the midfoot, but even the hind foot. Like sometimes I'll see people who have a bit of a restriction in the like calcaneus, which is like your heel, like the joint in there. And so this tendon might be working overtime to try and compensate for something biomechanical that's going on. So we definitely want to make sure we're addressing any foot or ankle biomechanics that might be happening. If there's stiffness at the ankle joint or things like that, then we want to make sure that we're restoring those normal mechanics so that the tendon has the best chance of functioning properly or quote unquote normally. We want to look further up the chain. So with these, I'm really especially looking at turnout oftentimes. So looking at range of turnout, looking at control of turnout, looking at how well a dancer is able to utilize and hold their turnout. Because one thing that we commonly see is if a dancer is maybe not as strong, or maybe they're just not utilizing the correct muscles to kind of initiate or hold their turnout, they will often end up compensating by kind of rolling in through their foot a little bit. And that rolling, especially through the medial arch, forces this FHL to kind of work a little bit harder in through there, puts it at a bit of a biomechanical disadvantage. So we definitely want to address turnout for sure. And then I'm always looking at core and pelvic sort of stability and control in through there as well, because again, we will often see distal areas of the body, so in this case, the foot and ankle, compensating for weaknesses that might be happening more proximal in the body. So the core or the pelvic girdle or things like that. So we want to make sure that we're looking at that and assessing that. So if there's anything that's contributing from higher up that kinetic chain, that we're dealing with that as well. We want to look at the intrinsic muscles of the feet. So these are the tiny little stabilizer muscles of the feet. And we want to make sure that those are functioning really well, because if dancers aren't able to utilize and access those muscles really easily, then they will often end up compensating through other muscles in the foot or the ankle. And so that's one of the things that we're always going to look at when we're dealing with any type of foot and ankle injury, but specifically with FHL issues as well. Then, and this is maybe the biggest one for FHL stuff, is we really want to look at their dance technique, especially when it comes to pointing their foot or rising or relevating. And if they're a ballet dancer and they're doing point work, we definitely want to be looking at the mechanics of that as well. Because a lot of the times these FHL issues crop up because of some kind of technical faults or technique habits that maybe a lot of dancers have. And one of the ones that we can see a lot is dancers who get really used to winging their foot. And so it's a stylistic thing. It's very kind of desired or sought after in certain genres of dance, maybe not so much in others. But a lot of dancers might sort of be aspiring to kind of develop a bit of a wing in their foot, which if that foot is not weight bearing, so we have our leg, I don't know, say in an arabesque, and so we want to wing the foot a little bit to like kind of enhance that line or what have you, that may not be problematic. But a lot of dancers, if they've been practicing that or working on that, they end up winging, for lack of a better word, it's not actually winging, but doing the same thing when they're on demi-pointe or even point. And sometimes you'll hear it referred to as like beveling, like in a point shoe, or on point. And that can definitely contribute to FHL issues if we are sort of like thinking about or trying to, and maybe not even trying to, but it's happening that they're kind of winging or rolling inwards as they're coming up onto demi-pointe. So there's more load going through that FHL through the medial arch than if they were coming up in a more quote unquote neutral position where we're going to keep the force dissipated across the foot a little bit better in through there. So we definitely want to look at like that aspect, like technical aspect, and it is often, like I said, like an aesthetic thing. And so making sure that dancers know sort of when it might be okay to wing their foot if it is sort of a lifted leg and there's no weight going through it, versus when it is our weight-bearing foot, what the alignment of that should look like. And then we also want to make sure we look at how a dancer is like pointing their foot, how they are utilizing their foot when they are just pointing. So whether it's doing a tendu or whatever it is. And this is really important, especially for teachers, to look at with dancers not having their shoes on, because you can't see exactly what the toes are doing if they're in like a ballet shoe or wearing socks or things like that all the time. But what we commonly will see is that dancers are really scrunching their toes as they're pointing their foot. And so rather than pointing and articulating through the ankle and then sort of through the midfoot and then just lengthening out, so being able to access their lumbricals and the intrinsic muscles of the foot and lengthening the toes, they're actually scrunching the toes in through there. And that is one of the like probably biggest causes that I see of FHL issues, is like that habit that dancers have developed of over pointing or over kind of scrunching or whatever you want to call it, their toes. And so breaking that habit is really important to be able to sort of address the mechanics of the foot kind of long term so that this does not become a recurrent injury. One of the things I always have dancers try and do, and it's like sometimes surprising the dancers that struggle with this, is having dancers point and flex their ankle, but keep their toes in a slightly extended position. So rather than allowing their toes to point as they're pointing their ankles, I'll ask them to point their ankle, but keep their toes pulling back or keep their toes extended. And a lot of dancers struggle with that motor patterning or that movement sort of program. And so really having them be able to plantar flex their ankle, but without using those toe flexors to help them. If you remember back when I was talking about how the FHL can act as an ankle plantar flexor, but it's not its primary role. If dancers are over relying on that, they're going to struggle with this. And so we want to retrain that, teach them to use the primary ankle plantar flexors. So our, depending on what position our leg is in, our gastrocs, our soleus, whatever other muscles we're using, depending on what we're doing, we want to teach them to use that, but without using the toe flexors, or in this case, the big toe, the hallucis flexor, at the same time. And that can be a really hard movement pattern for some dancers if it's really ingrained in them to be scrunching their toes, curling their toes, doing whatever it is they're doing with their toes. And that's often a pattern that's been ingrained from when they're really little. And I think I've talked about this on the podcast before. I've certainly talked about it on social media before, but the words that we use and the language we use with dancers really matters, and especially with really little dancers. So when we have a lot of dancers who have danced since they were 2 or 3 or, in little baby ballet classes and stuff, they often used to use the terminology of point your toes. We'd always tell kids, point your toes, where are your happy toes, whatever language we were using. And that, I think, feeds into this idea that when we are pointing our foot, the movement is coming from our toes. And really, we probably should be saying point our ankle or point our feet or whatever it is that we're talking about. But we will see that, and a lot of times I think these ingrained patterns, because I see it really commonly in the dancers who have danced since they were really little. If we have a dancer who's come to dance later in life, it's less common that you'll see that toe scrunchy pattern where they're really overusing their toe flexors. But when we have dancers who have danced since they were really little, it's a common thing that we'll see. So really working on retraining how they're using their foot and which muscles they're accessing when they're pointing and articulating through their foot is a huge one to be able to make sure that we are accessing and utilizing that Flexor Hallucis Longus, FHL, efficiently in through there. All right, I think that's all I have to say about the FHL right now. Like I said, definitely go check out the episode on posterior ankle impingement, though, because it is not always an FHL issue. Sometimes we're dealing with a posterior ankle impingement of some of the other soft tissues. There's other muscles and tendons that cross the back of the ankle joint with the FHL, so they can be problematic sometimes. And sometimes we might be dealing with a bony impingement or something like that. But the FHL is a really common injury that we see very frequently in dance, but is often missed by other healthcare professionals, or misdiagnosed is probably the right word. It very commonly gets misdiagnosed as an Achilles issue. If people are getting pain in the back of their ankle, it's just they have an Achilles problem, but then they're not responding to treatment protocols for Achilles tendinopathies. Or, like I said, if they're getting pain more along the medial arch of the foot where the tendon kind of comes into the big toe, it'll often be misdiagnosed as a plantar fascia problem as well. So we just want to make sure that we are making a correct diagnosis so that when we're looking at loading management and how we're going to work on treating this, that we're addressing the right structure of the foot. So I hope that was helpful for you. I hope that this becomes an injury I don't see as much as I really like treating feet and ankles. I could see less of this right now and be very happy about that. If you have any questions, comments, want clarification on anything in today's podcast episode, please reach out and let me know. My contact information is in the show notes, and I hope you have a great rest of your day.